We have only a certain time to go through everything. And that means that patients have to be advocates for themselves. And it's important to understand the basics to ask. And when you go to your urologist for your urinary symptoms, sexual function goes along with it. And don't be afraid to bring it up and to really see how you can address it. Because there are things you can do to change to improve your sex life.
We are here in another episode of the Erectile Dysfunction Radio podcast. Today we are joined by Dr. Joel Hillelsohn. Dr. Hillelsohn is a board-certified urologist at New York University Medical. He also serves as a clinical assistant professor at New York University Grossman School of Medicine. Dr. Hillelsohn joins us to discuss BPH, the treatment options, and which ones are best suited to facilitate good erectile function. Dr. Hillelsohn, thank you very much for being with us.
Thank you for having me, Mark.
So to get us started, can you give our listeners just a description or an overview of what exactly BPH is and how does it impact the body?
It's a very good question, Mark. So, as fortunately as we age, and specifically at age 50, testosterone gets converted to DHT, which causes our prostate to grow and kind of our hair to fall out. Not great things that can happen to all of us. Now, the prostate is an organ that lies in between. If you look at the bladder, think of the bladder as a balloon. At the neck of the balloon is the prostate. As it grows bigger under the influence of testosterone, inflammation, it narrows the orifice, so therefore it decreases our ability to void and to empty. Now, patients get many symptoms of BPH, but it's unfortunately highly prevalent. According to some studies, at age 60, 50 to 70% of the population, male population, will have some aspect of BPH. Now, what does BPH have to go with erectile dysfunction radio? Well, unfortunately, they're highly concordant. There are various theories that are bound why erectile dysfunction and BPH go together. But it's clear that there is a clear linear correlation between the two. Now, the nerves that govern erection are the outside the prostate. That can play a role. BPH is an inflammatory condition. But it is clear that when you have a patient that comes in with BPH or with ED, they often have both together.
Okay, so Dr. Hillelsohn, can you give us a little bit more of a descriptor, though, of what exactly is BPH? What are some of the symptoms that people would experience? Who's prone to acquiring BPH and whatnot?
Sure. So BPH, which stands for benign prostate hyperplasia, is basically a condition when your prostate grows. Part of the prostate is a prostatic urethra, where it grows into, as I used the definition of a pipe, as it grows into the urethra itself and narrows the opening. Typically, patients will describe having a weak stream, intermittent flow of urination, frequency of urination, kind of this feeling of incomplete emptying. They vary between each patient. The reason why is more because of the pressure itself. Think of the bladder like a balloon. As the bladder has to push past a narrowed opening, it gets thicker and it loses elasticity. So therefore, you're not able to hold as much urine. And in terms of what typically patients will describe this, over time, I'm noticing my stream is weakening and I'm getting up a little bit more at night. Sometimes I have trouble initiating my stream in the morning. Or some patients will have some bladder prevalent symptoms. I feel like I have to go, every time I go somewhere, I have to plan out where the bathrooms are. My wife is bothering me. I always have to go pee. And those are the typical signs of BPH.
Okay, so it sounds like a lot in the urination. department. I mean, people like are experiencing more frequent urination, a sensation of like having to void much more than going to the bathroom and whatnot, and it could be also just like weakening of a stream. I imagine also waking up in the middle of the night multiple times to urinate is an uncomfortable symptom of this condition.
Yes, and it's unfortunately quite prevalent. It's one of the number one reasons patients see urologists is for BPH. You know, and it is, and unfortunately, it can take a real toll on patients' quality of life. You know, really having to sit in front of the toilet and have this uncomfortable feeling like you cannot pee. Now, and of course, it can develop to a state where it can become dangerous, but that's more for a long term. Most patients come in to a urologist relatively in the early stages of what we call BPH.
Okay. Is there any urinary incontinence associated with BPH as well? Or is it generally the opposite, feeling like you're not getting enough out as opposed to not being able to keep the urine in?
It's a good question. Now, people think of, and as we just described, BPH as being a symptom of having a poor urinary stream, but there is another organ being affected, which is the prostate. Now, everyone responds differently. Different bladders respond differently to this obstruction. Some bladders will respond by getting more muscular and getting thicker. And in those patients, if you ever try to think of the bladder, it's not a very, doesn't do a lot. It's just literally storage. It stores urine. Now, it should be thin, like a balloon, fill up easily and empty easily. But if it is obstruction, it gets thicker, then it can't hold as much urine. And if it can't hold as much urine because it's filling up with a high pressure, it will spasm and it will cause incontinence. And other patients, their bladder just simply stretches out. And these patients are like, I feel fine. I'm only peeing twice a day. Well, that's not normal if you're peeing twice a day. They just pee a little bit and they have a lot left behind. It
Okay,
depends
maybe
on
the storage tank expands, so
it
they don't really have
expands.
that need to
It
pee.
expands. And those are really the silent ones where you really have to worry about, a guy who comes into my office, and his wife came in. He said, my husband, they put a catheter in my husband because he couldn't pee, but now his stomach's gone. And then I looked at his old records, and it turns out he only was peeing till he had 2 liters in his bladder because it was somewhat insidious. Those are the cases that kind of where it's masked because it's stretched out. But anyway, no two patients are the same. Some patients will have predominantly storage symptoms, and some patients will have predominantly emptying symptoms. But it's all part of the whole same overall. It's the whole same condition where it's lower urinary tract symptoms being caused by an enlarged prostate.
Okay. And do either of those tracks or are those manifestations, do either of them lead towards an incontinence, or is that not really like a symptom that one would be looking for or expect to be experiencing with BPH?
Well, as when the bladder gets thicker and it gets more muscular and it doesn't expand as much, when you spasm, you can get urge incontinence. So
Okay.
you leak because of urge. Stress incontinence is typically a syndrome when patients have their prostate removed from a surgery and they're unable to hold it in. But men at later stages of BPH or lower urinary tract symptoms will get urge incontinence.
Yeah, the reason why I'm asking that question and I'm harping on that is because I know that some of the patients I've worked with, and I'm sure you've seen this as well, urinary incontinence can be a very distressing condition, but it also can impact like the psychogenic aspects of sexual function because a lot of men are preoccupied with trying to make sure nothing is leaking. They also don't feel good about themselves. They're worried about leakage even during the act of sex. So just wanted to see if there was a connection here with BPH as well.
Yeah, that's a very important point. And I think what you're describing typically is what we call as climacturia. When patients, when they ejaculate, they can leak urine. It usually happens when the prostate is removed because the prostate itself is able to keep the urine in. But once the prostate's removed, let's say for prostate cancer, that's when we typically see this kind of stress incontinence. It's kind of unusual to see it just from BPH alone. Usually you'll be seeing is urgency.
Hmm. Yeah. Okay, so can we move over a little bit and just talk about the potential connections or the connections and the potential theories or explanations of this link between BPH and erectile function, erectile dysfunction?
So we do know there is a connection. And I was actually just doing a literature search to see if there's any new big theory out there. There are four main theories, but each of them are very esoteric and are unproven. But I think what it comes down to, and then the most commonly accepted hypothesis, is that BPH as an inflammatory syndrome has, um, we do know that when it grows, it's typically inflammatory, and the nerves for erection run on the outside of the prostate. So that can irritate the nerves that initiate erection, which in turn influence the nitrous oxide production. Now, what is nitrous oxide? Nitrous oxide is what our nerves secrete in order to open up the penile artery to help our erections. Now, there's two things that go on with it. I mean, I'm sure you're familiar. I'm sure some of your audience familiar with kind of the concept of the sexual tipping point. But the issue when it comes to erectile dysfunction is that the psychogenic component is such an important and almost I'm pressed to think of a case of erectile dysfunction that's purely organic. Once your erections start decreasing in quality, once you start worrying about your erections, you can't help but to worry about it and secrete adrenaline, which leads you to have worse erections. And it is unfortunately a bad cycle that it's very hard to break.
Yeah, I mean, it's a really, really important point, one that we do stress here. That again, like I also obviously in the work I do, like it's almost exclusively psychogenic. But just for our listeners to also hear that from the medical side, that it is very, very difficult, if not impossible, for somebody to experience erectile dysfunction one, two, three times, even if its initial causes have a big organic component, and then for them to not worry about it afterwards. So there's always going to be like a psychological piece at play. Now, to that, and when you were mentioning the nerves that run alongside or very close to the prostate, what that reminds me of is some of the episodes we've done around prostatectomy and how those nerves can be, at least temporarily, stunned or damaged and have to go through a healing process. Are we talking about those same nerves?
Yes, we're
And are we
talking
talking
about
about
those same nerves.
okay? And what precisely, or what I guess happens to these nerves with BPH or with untreated BPH? In this theory, at least.
Well, the theory is that it leads to inflammation of the nerves. Now, we know that prostate by itself, if you have an untreated BPH, sometimes you will have incomplete emptying of urination, which leads to bacterial overgrowth. Because think about it, if you go camping, you don't want to drink water from a lake that the water is just sitting there. The biggest defense our body has against bacterial overgrowth is keeping urine flowing. So if your urine's not flowing, you can have bacterial overgrowth, which leads to inflammation of the prostate, which leads to subacute, sometimes prostatitis, which will irritate the nerves, which will make your erections not as good, which will make your ejaculation hurt. And it's quite a distressing thing to happen when you ejaculate, you see blood in your semen, or you have pain. And it'll make you subconsciously avoid it. And at least in what I've seen in patients, it leads to worsening erectile function. Now, of course, we know that erectile dysfunction also goes with age. The same patients in the same age group that are having BPH typically will get erectile dysfunction organically. So it may be an association just from age alone, but based on the amount of studies that have shown such a high correlation, it seems unlikely. Now, speaking of that, we treat BPH, but some of our treatments have problems with erectile dysfunction, and they kind of go hand to hand. So,
So, Dr. Hillelsohn, I'm sorry, just going to slow you down for a moment. Before we get to the treatments, I'm just wondering, are there any other like prevalent theories as to what might be going on? Maybe something that pertains a little bit less to the nerves. Maybe there's another alternate explanation that would be just insightful for our listeners, even if it doesn't actually hold water or it's something that you don't see empirically in your clinical practice?
There is there is one theory that was seen about penile ischemia, that there is less blood flow to the penis going on at night, secondary to the association with with the with the pudendal artery. There is another. There is some more kind of there is more of there's another theory about to do with systemic, inflammation that has to go not with the nerves, but just with hormonally, that there's hormonal changes that happen within as the prostate grows, which can affect your ability to, have erections. But it is it is also common that our treatments, even medication wise, that patients will take, even over the counter, can have effect on our erections, which kind of worsen it.
Okay, all right. So let's move over to the treatments and get a sense of how BPH is addressed and what some of the considerations are with regard to um, wanting to obviously address this inflammation environment, but also having to balance that with some of the potential impact on sexual function and erectile function.
So, most patients do start off with medication for prostates. And I mean, it's very common for a patient to come in given a popular medication, is Flomax, tamsulosin. It's the most popular medication. It's been around for a long time. What it does is it relaxes the prostate fossa and allows you to urinate easier. However, many patients are distressed to notice that all of a sudden they have retrograde ejaculation. And it comes to a surprise to them. They weren't told about it, and and they just worry that something's really physically wrong with them. That they just all of a sudden I orgasm, I don't see anything, and that is common with medications like tamsulosin and with Rapaflow. Uh,
For Dr. Hillelsohn, for our listeners who are just joining us at this episode or haven't heard all of our previous episodes, can you just give a quick descriptor of what retrograde ejaculation is?
Retrograde ejaculation is that when you ejaculate and the semen leaves what we call the vira montana, which is actually in the center, is like the entrance of the prostate. Instead of going antegrade, meaning out to the urethra, it goes backwards into the bladder and mixes with your urine. So when you urinate after your orgasm, you feel the orgasm, but just nothing goes out, and it ends up coming out in your urine afterwards.
Okay, this is saying is one of the side effects of
Flomax.
a medication like Flomax.
Flomax.
Okay.
There are other medications that are used for the prostate, such as alphazocin, that do not have these side effects, and I typically will switch my patients over to those just because there is a psychological effect about having a dry ejaculate. Another medication that's very common, and I'm sure you've discussed in your podcast many times, is finasteride Proscar.
Well, it's also a hair loss medication,
Yes,
correct?
Propecia is taken at 1 milligrams, finasteride is at 5 milligrams. So what this medication does, and I discussed this, I think I briefly mentioned earlier that one of the leading theories of why patients get BPH is testosterone at age 50 starts getting converted to DHT, which causes hair loss and prostate growth. Now, finasteride or dutasteride, they block that conversion of testosterone to DHT. However, there is something called post-finasteride syndrome, in which young men get debilitating decreased libido, decreased erectile function, feeling the penis is numb from taking Propecia 1 milligrams. Now, finasteride, we don't see it as much in the older population, but finasteride, when it's given, I often will warn my patients, this can decrease your libido, this can decrease your erections. And I do see it happen in some of my patients where they take it and then they have a really marked decrease in libido. So patients need to be aware of it because it's these medications, Flomax, finasteride, they're very they're very widely prescribed without even a discussion at all. And the next thing you know, I can't have an erections and I can't see an ejaculate, and that's a real shock.
Meaning you're saying when a lot of these medications are prescribed for urinary issues, hair loss, or whatnot, patients are not always receiving the proper information about what they might expect
Yes.
as a result of some of the side effects. They don't have that awareness, and they come back to a doctor or to a prescriber with these complaints, and you're saying they can be quite common. It'll be helpful if patients were aware of these side
Of course.
effects.
And they're aware that there are alternatives out there. I mean, I had a patient come to me last week. He just happened to be this size. Like, I haven't seen an ejaculate in 2 years, and I think I'm infertile, and I just haven't thought about it. And I'm like, well, you've been on Flomax for 2 years. And it was a shock. He's like, no one ever told me. I got on Flomax. I had a kidney stone. Someone gave me Flomax. I went to the urologist, said continue with it. And then I just thought I can, this is my aging. I just can't have an ejaculate anymore. And this is, we have limited times to see patients. We're all under the same limits. We have only a certain time to go through everything. And that means that patients have to be advocates for themselves. And it's important to understand the basics to ask. And when you go to your urologist for your urinary symptoms, sexual function goes along with it. And don't be afraid to bring it up and to really see how you can address it. Because there are things you can do to change to improve your sex life. Getting off the finasteride, getting off the finasteride, or switching your medication for urination, switching from Flomax to alfazocin. Well, often, which alfazocin is a similar medication to Flomax, but it's a little bit more selective for the prostate. Therefore, it's less likely to cause a retrograde ejaculation, can make a very big difference in patient's life. And in addition, we know that there is some evidence that alfazocin itself and Flomax can improve patients' erections as well due to alpha stimulation. So what's an alpha blocker? Some alpha stimulation. When we talk about psychogenic ED, right? That's
Mm-hmm.
epinephrine. That's adrenaline, fight or flight. You see it on a penile Doppler. I have a guy sitting there. He says, I can't get an erection. I give him an injection, and I say, and he said, look, it's not hard. I say, well, okay, look out the window. Think about something else. He goes back, it's rock hard. Adrenaline will lead to a venous leak. The blood flow comes in and then it leaks out because adrenaline stimulation shrinks the corpora and allows the veins to keep open, allows the blood to come out. Now, if you had an adrenaline blocker, like an alpha blocker, that can help you overcome it. So that's probably why alfazocin and Flomax help erections. But in general sense, you can switch to something that doesn't affect your sex life as much.
So it sounds like there's a number of ways to address both BPH and any subsequent or many of the subsequent sexual issues that could emerge. Now, I do want to say one thing that I think it's important for our listeners to hear, because I do know that some of the providers that I've worked with have shared with me just a real challenge that when people come in with distressing conditions like urinary problems, risk of cancer and whatnot, because they are so focused, understandably, on trying to resolve that issue, even information that is passed on in these very brief, like, appointments will oftentimes get lost. So sometimes providers are mentioning you may experience some sexual side effects, but it oftentimes is about as quick as like a drug commercial where they say you may experience the following side effects. So that information sometimes is given over, but in just the intensity of the appointment coupled with just the patient's distress and focus on the primary presenting condition, it does get lost. So that's where I think, Dr. Hillelsohn, when you were mentioning about like patient advocacy, it's really, really important, like really important, because there's only so much that a provider can do in the time allotted to see you. And even they might mention 10 side effects all in one shot. Ask for information, ask for a follow-up, ask for a good resource. I think these are things that could be helpful in creating that good relationship between doctor and patient, and really like collaborating to tackle these conditions well.
It's a very important point, and you see it every day. I tell my patients I'm more of a quality of life urologist, so I try to get through everything, but you can get lost in the minutia. Sometimes I like explaining things in details, and the patients kind of really get lost. I say, message me afterwards, digest and come back. But it's very easy to get lost in in the sometimes the flood of information about your primary condition that you lose anything that's secondary. Now, there was one other thing I didn't bring up, Mark, and this is a medication that's something that most patients are familiar with, Cialis. Cialis 5 milligrams is one of my favorite medications for BPH and erectile dysfunction. It's used for both. If I have a patient who has a little mild urinary symptoms, I will give them Cialis daily. And it's vitamin, we like to call it vitamin C for the penis. It increases blood flow to the penis, increases blood flow to your heart. And there's also nitrous oxide receptors on the bladder neck. So it reduces the frequency of urgency of urination. And this is a way these two conditions can be treated both at the same time. And many of my patients' benefits, I think I tell my patients the only drug I give patients that they don't want to give back, they don't want to stop, like the Viagra trial, they gave it for high blood pressure and no one wanted to give it up at the end. It's the only medications patients thank me for because they kind of feel like they're 15 again. They're walking around. When they see something that turns them on, the nitrous oxide gets released and it's just being blocked from going away. So all of a sudden you have a response down there. And this is a way these two conditions can be treated concomitantly.
That's very interesting. I have worked with a couple of people over the years, and I really didn't fully understand it until you just explained it a little bit more. That said they were on Cialis daily, but it was primarily for BPH.
Yes.
But that's actually helpful. That's definitely helpful to know. And I think they were, obviously trying to kill two birds with one stone.
Yes.
With Cialis. So just as a side note, Cialis is one of the medications that it's longer acting, but it does require that stimulation. Is that unique to the receptors that impact erections, or is there stimulation necessary to activate this in the bladder or in other areas where Cialis may be working?
Well, to break it down like simply, Cialis is a PDE5 inhibitor, so that's just an enzyme. What do enzymes do? Enzymes break down protein molecules. So nitrous oxide is released from our nerves when you get turned on, when you want to have an erection, and it simply blocks it from being broken down. So you have more nitrous oxide and the blood flow goes into the penis. However, there's nitrous oxide everywhere in our body, which is why you hear you can't take it with nitroglycerin for a heart attack. You have nitroglycerin. And that's why patients will find that what are the most common side effects of Cialis, Viagra? Gastric reflux, nasal congestion, headaches, because it can drop your blood pressure. When Cialis is taken at a short, low dose, long-acting, low dose, it increases nitrous oxide everywhere in the body. And as I said, nitrous oxide is in the bladder. It seems to relax the bladder musculature. And between me and you, the symptom scores that we use to detect patients' urination improvement are a little subjective. And it's my personal opinion that patients will write that they feel better with their urination because once they're on Cialis daily, they feel about everything in their life. And I think that's part of it as well. You just feel good. And if you feel
Yeah.
good, you don't care as much as you wake up one time at night. I'm back, baby,
Yeah,
But
you're saying there's an overarching
it's overarching.
psychological
It really
benefit
talks
to
about how important erections are to quality of life. It makes you feel
right.
like a man. And then you don't care about it going a little bit weaker. But in a general sense, yes, Cialis is everywhere. Nitrous oxide is everywhere in your body. And the good thing about Cialis daily, and now this is really aside to BPH, but I find that patients who can't tolerate Viagra, if you take Cialis daily, all of a sudden they're able to tolerate Viagra on top of it because your body's used to the extra nitrous oxide that's been around already because it's the same enzyme. So no need to have a huge amount of the medication in your system like Viagra, which leads to a spike in the blockage of the enzyme. The body's already used to a little extra nitrous oxide, so you can tolerate a dose of Viagra on top of it if you couldn't do it before.
Okay, so Dr. Hillelsohn, this is really, really informative. I want to bring this back and get like a little bit of a broad picture here. So I'm just going to throw a quick case. You have a 28-year-old or a 30-year-old comes into your office and seems to be describing like constant, frequent urination, going to the bathroom a lot, waking up at night. Like, is this going to indicate to you BPH? Now, obviously, it's a differential diagnosis, so I don't want to pigeonhole you here in that sense. But are there other things that could be going on, or are better explanations in younger men when they're having these symptoms, or is BPH something that really could like be impacting people at any age?
It's fairly unlikely in a young age. And that's basically comes from the data that we do know that patients who are younger, who have these symptoms, we really need to treat them almost like the pediatric population. The prostate is usually not that enlarged. It's usually dysfunction avoiding pelvic floor dysfunction, which is really too broad to talk about in a brief session, especially since we didn't even talk about surgical treatments for the prostate. But the concept is that these kind of patients are typically higher anxious. They strain to pee like they poop, and then they close their sphincter. And it almost gives them very similar symptoms that you see with an enlarged prostate. So they're peeing, their sphincter closes up, they get post-void dribbling, like this incontinence when they're done. There are patients who are almost like shy voiders. They have difficulty initiating the stream, they sit down, but it's part of the diagnosis, but it's not as likely. When I tell patients, pour urinary, I do a flow test. I see how fast it comes out. If it's coming out fast, it's not an obstruction. If it's obstruction on a young man, I'm thinking stricture, I'm thinking pelvic floor dysfunction, I'm thinking sometimes a little altered anatomy like an elevated bladder neck, but things, not the most common things. If I have a 6-year-old that's coming with an obstruction, I'm
You're
looking at
thinking
BPH.
BPH. Yeah. Okay, now, that's very, very helpful just to kind of give me and our listeners always just some like parameters of how common this is. So frequent urination does not mean at all ages that it likely is BPH, but it sounds like as men age, and you said it seems to be like 50 and on is when BPH is going to be one of the top considerations in a differential
And it's
diagnosis.
and it's yeah, and it's difficult for patients to kind of understand if I have frequency of urination, why is it my prostate? But unfortunately, there's little we can do if your bladder needs to push hard to get urine out. Most of the meds and the treatments we have for overactive bladder weaken the bladder. So you can't weaken the bladder if there's obstruction. So you often have to treat the prostate first and then deal with the bladder. But it's basically the equivalent of is if you hurt your knee and then you start walking weird and your heel hurts. You want to fix the heel, but at the same time, if you don't put a knee brace on, it's never going to get better.
Okay, that's a really helpful way to think about this. So, Dr. Hilson, to wrap things up, like for any man, any age, who's experiencing again a noticeable increase in urination, they're waking up at night. Like, what advice would you give them? Like, who should they turn to? What should they do?
So the first thing would say that this is a quality of life issue. And don't be afraid to see a urologist to get it evaluated because the bladder has a certain amount of elasticity. So if your prostate's obstruction, your bladder can undergo some changes. And if you don't kind of get on top of it, it's only going to get worse with time. And every study shows that the prostate does not stop growing throughout your age. So by treating it earlier, often we prevent long-term changes to the bladder that will affect your quality of life later on.
Okay, Dr. Hilson, so you mentioned a number of medication options that are available, but like many urological conditions, including erectile dysfunction, there are medications, and then there are other ways of trying to address these conditions. Does BPH have any alternatives to medications? Are there any treatments available that do not require medicine?
Of course. So in the last 10 years, we've seen an evolution in our surgical treatment for BPH, where we've gone from patients having just scraping the prostate like a TURP or lasering it to a litany of treatments. Feels like every 6 months there's another new treatment for the prostate out there. And now the real advantage is that patients who are afraid that their treatments for their prostate would cause them erectile dysfunction now have more and more options available to them. Because as Mark, as you said, all medications have side effects. So it is somewhat advantageous to our patients to consider hey, I can just put, for example, a balloon in my prostate, inflate it, let it sit there for 10 minutes. We take it out, and I don't have to take medications, and I pee, and I pee like I'm 30 again. Or aquablation, where we use a robot to kind of carve out the prostate. We talk about the nerves that are at the end of it. Think of the prostate like an apple. You want to carve out the prostate and leave the peel intact. I can do a treatment for 45 minutes, carve out the prostate, allow it to be wide open. I urinate better. And honestly, most patients get stronger erections because there's less inflammation. And and I don't have to take medicines for the rest of my life, because one less medication is often very, very important to almost all of our patients.
Okay, so what I'm gathering is that you're saying in the past, number of years, there have been like treatments that have come onto the market that are not medically based. They're not, generally do not have the same type of side effects and shouldn't have like any impact on sexual function. Is that correct?
Yes, yes. There's
Okay. If you are and we could talk about patient autonomy. It's a topic we've covered in other podcasts and whatnot. So I don't want to go too far down into that piece. But if a patient asks for your advice and a primary concern for them is sexual function, is this like a route that you would encourage them to consider? All things being equal, without getting into the details of any particular case, like is this a route that you would encourage, that you would recommend over a medication option, or would there still be a reason to pick medication over a procedure?
I think I had a patient today who just came in and said, I my biggest concern is I don't want to have any decrease in ejaculate. I don't want to risk it at all. And I said, any of the medication I give you, it's a possibility. And I showed him some of the more minimally invasive option. I think for him, he's going to probably elect to do something called an Optaloom for BPH. The specifics are not important, but patients should not be afraid. Traditionally, they may have had friends 10 years ago who said I had a TERP or a green light or another procedure that resected the prostate, or they get it confused with prostatectomy. And they're like, well, I went to my primary care doctor. He gave me Flomax and he gave me some other medicines. I still wake up 5 times a night. My stream is weak, but I'm too scared of any surgical options. These are not really surgeries. We kind of call them procedures. Some of them can even be done in our office. A lot of them can be done awake. And we have come to a point where some of these procedures have a 0% risk of erectile dysfunction. And that's an important thing that patients need to be aware of, that there is something out there that can preserve your sex life and get you off medicines for urination and improve your quality of life.
And it's also really, really important because a lot of times patients are picking up information that is outdated.
Yes.
They heard about an uncle or a cousin or somebody who went 6 years ago, 7 years ago, and did not have those kind of results. And I think, Dr. Hillelsohn, what you're bringing up is that there's new techniques and approaches that are continuously being developed here, and there are currently procedures that really offer very promising results and outcomes without the unwanted side effects. So it's important that patients ask, they inquire, and there really are ways to address BPH among other conditions that really have minimal to no effect on erectile function or on ejaculation.
Yes.
Okay. Dr. Hillelsohn, this has been excellent having you on. I really, really appreciate your time.
Thank you.